Okay, so I'm going to start. Okay, so this protocol was put out, I think, a week ago, or maybe a little more than a week ago. I sent it out to Donna, so she thought it would be a good idea to go over it. It's not anything dramatic of a change, but just to clarify, you know, what you may be seeing done and not done, because for some people it may be a little different than what they're thinking. So the first thing is, this is termination resuscitation. So there's going to be situations where you have a patient that resuscitation is never started, right? And that's because of one of two situations. One would be that they have an advance directive, you know, directing you not to resuscitate them, okay? And the other one would be that they're already been down dead for a while and there's no purpose in resuscitating them. So let's do the first one, which is the you know, the advance directives. So we know that in New York State, EMTs are obligated to honor two types of advance directives. The first one is a out-of-hospital DNR, okay? And the second one is a MOLST form, Medical Orders for Life-Sustaining Treatment, MOLST. So if there's a valid out-of-hospital DNR or a valid MOLST form, we do not resuscitate the patient, right? Even if they're freshly dead, they die in front of us. You know, we do not resuscitate the patient because they put their healthcare wishes, you know, in writing, telling us not to do that. Now, it has to be completely filled out, signed, you know, and dated, the whole 9 yards, depending on, one form is very in detail, the MOLST form. The out-of-hospital DNR is very basic. It just says the patient's name, do not resuscitate, the date, and the doctor's signature. That's all it has. The MOLST form has multiple patient demographic pieces of information. Now, a couple weird things about a MOLST form. One is they never expire. So even if the thing is 20 years old, technically it's still good. Now, it does say that it's supposed to be updated every 90 days, but even if it's not.
Frank, I'm sorry to interrupt you, but I have like 3 people texting me. I have Brandy, Candy, Lisa. They're all telling me all different things. Like Lisa says, I have a sign-in screen, so I just told her to put her name and email. I have Candy telling me something different. I have Brandy saying I can't log in. Why not? And I'm like, what am I supposed to tell these people? Like, it's killing me.
Tell them they should have started this process at 7:15 like the rest of us.
I don't know.
How about that?
I don't know what to tell them. I'm like, Candy's like, I can't get in again. Ugh, what is going on? Help. And I said, come over. And then I said, when you click on the Zoom link, what happens?
What is she using to get on? I mean, if she's going through, if she made a Zoom account, she should be able to click on the link and get right in. You know, if she's going on a computer.
I know. I had a problem the one week, but I refreshed my computer. But one week I couldn't get in at all, and I had to redo the whole thing. I don't know.
I don't know either. Well, it's being taped, so if worst comes to worst, you could watch it on YouTube. So,
all right.
You know, I'm taping.
I'll be right back.
I'll put it back up on YouTube. Okay, so going back to this. So we have the situation where we, I'm just gonna mute everyone so that it's quiet for a second. And then if anybody has a question, just unmute yourself. Okay, so the first situation would be that the patient has some type of advance directive. Okay, so we said that they never expire, even though it says on them they're supposed to be updated every 90 days. Even if they are not updated, they're still good. Okay, but they have to be properly filled out. They have to be visible to you. Now, there's a gray area if it's electronic, right? So, you know, usually we see it in paper, but let's say somebody has it on their phone as a PDF or something like that. What I would do is have them send it to you so you have a copy to print out and attach to your PCR. If you're uncomfortable with it, you can call medical control and ask them for, you know, their take on it. But, you know, an electronic, properly filled out document that's readable would be acceptable too. Okay. Now, there's such a thing as an in-hospital DNR. So let's say, I think you guys go to the hospital and bring a community member home, right? If you had that situation, you had a resident of the village that was at Nyack and they needed to come home. I think, you know, if you have manpower, you would go and pick them up and bring them home. I remember you were doing that for a while. So let's say that in the hospital that patient has a DNR. They don't have an out-of-hospital DNR yet because they haven't seen hospice. So the in-hospital DNR covers them for the trip home. So while they're in your ambulance, they're covered. Oh, Candy's getting on now. Okay, Candy Goswick's getting on now. So while they're in the ambulance on the trip home, that in-hospital DNR does cover them.
Don't yell at me, Frank. If it says to ask somebody an ID number, what do they put in?
It's on the email. I think it just was PFD was the password. I don't know.
Well, it says password. There's no number. She's showing me a number screen, and it's saying, what's the ID number?
Hold on. Let me look.
I see. I sent her the email.
Hold on. Okay.
I have 819 54 73 66 16.
Wait, let me read it again. 849-547-36616.
That's what I have, yeah.
I'll tell her to try that.
Yep, that is the meeting ID. It's right under the link you click on the email.
Okay, now Brandy's showing me her screen. Hers is saying the email, and then it's saying incorrect password, and she put in the PFD.
I don't know.
She's sending me a screenshot.
Did she click on the link?
I believe so.
It's really not that hard. If you just click on the link, it should take you right in. You know, you may have to put a meeting ID and a password, but it shouldn't really be that hard.
They're all capitals, PFD.
Yeah, PFD is all capitals.
Okay, so did Candy connect?
Candy's on.
Okay.
She
So
was
Candy's on. Lisa, I gave the ID number to. Let me see if I can get Brandy. I have Zoom meetings twice a week and never have this problem. This is like what happens. All right, hold on.
Oh. Jim, that dog's doing mouth to mouth with you.
We're practicing resuscitation.
Yeah, and you're enjoying it.
Oh, somebody has to kiss me.
Hey.
Yeah.
Correct.
Okay, so I'm gonna keep on going. I'll mute everybody. If you need me, just unmute yourself.
All right.
Okay. So so we said the situation where you're taking a resident of the village back home from the hospital. In the hospital, they have a in-hospital DNR. They're not yet issued an out-of-hospital DNR. So the in-hospital DNR covers them for the ride home, and you're bringing them in the house. So now what happens if that patient codes, right? So if you're transporting a patient who has a DNR from a nursing home or a hospital, they were alive when you left the hospital, because obviously, you know, you wouldn't be taking them if they weren't alive. But if they're alive when you're leaving the hospital or nursing home and they subsequently code, you're not resuscitating them because they have a DNR. So where do you bring them? So you bring them back to the sending facility. So if you left the hospital, you bring them back to the hospital. If you left the nursing home, you bring them back to the nursing home. So now you're going to see there's going to be some situations in this protocol that we'll talk that may be a little different, but that's, you know, that's basically the rule with it. Okay, and that you should bring a copy of the, you know, if there is such a thing, a copy of the MOLST DNR with you, you know, for documentation purposes. And, you know, with your EPCR, you're going to have a way of scanning and uploading documents to your, you know, your EPCR. They all do have that capability, but you may have to put a scanner or something like that in the firehouse to be able to upload the documents. Okay, so we were talking about when do we not resuscitate someone? Because the next part we have to talk about is when can we terminate resuscitation? So you would never think of starting resuscitation if the patient has an advance directive that's properly filled out. If you started resuscitation on someone because they didn't have the DNR and then the DNR becomes available, you actually stop resuscitation, right? So there's, you know, if you started CPR because they told you there was one, but they couldn't produce it, and then they subsequently produce it, you actually stop resuscitation at that point. The other time you would not start resuscitation is if the patient's obviously dead. So, you know, there's different signs that we could look for. The earliest sign you're going to see of somebody that's obviously dead is something called dependent lividity. So the dependent part of the body would be the part that's touching the ground. So if they die on their back, it would be the small of their back and the back of their thighs. If they die face down, it's probably going to be, you know, it really depends on their body shape, but it could be, you know, part of their stomach. It could be, you know, maybe the part of their thighs. It depends. Now, the problem is that the part that's pressing on the ground, not a lot of blood flow gets to it. So they don't develop this dependent lividity, because dependent lividity is the pooling of the blood when the heart stops pumping. So they get a purplish discolorization over the skin that's not in direct contact with the ground. So let's say they're on their back, because that's typically how we find most patients. Their shoulder blades are going to be touching the ground. So you're not going to see a lot of dependent lividity, but the small of their back would not be, because their buttocks and their shoulder blades would be touching. So you see it mainly in the small of their back, okay, and then behind their thighs, maybe behind their calves. And it basically looks like a bruise, a big bruise, a purplish discolorization. Typically takes 20 to 30 minutes to start developing. And if when you respond to an unwitnessed cardiac arrest, you find somebody laying in bed, that's the first thing you should be looking for, because if that is present, the patient is beyond resuscitative time, so there's no purpose in starting. Okay, the next stage would be rigor mortis. And the first place that you see rigor mortis would be in the jaw, where the jaw would be either difficult to open or close. Okay, and in that situation, obviously, that's further along. So again, the patient would not be resuscitated. If the patient has any type of mortal injury, right? So, with like yesterday, we had a bad car accident up on New Hempstead Road in Ramapo, and really both the patients that were taken to the hospital to be pronounced really should have never been transported. They had traumatic cardiac arrest, and traumatic cardiac arrest, has a very poor survival rate. So they were pinned in a car. It was extended extrication. They probably should not have been transported, but it was a kind of a cluster type of scene, so they were transported. So if you have somebody, has open brain matter, is bled out, has something impaled in their chest, something that's incompatible with life, again, you would not start resuscitation. So therefore, this new protocol we're looking at on the screen would never go into effect. So you get what I'm trying to say? There'll be certain situations that you would never start resuscitating the patient to start with. Therefore, this protocol, which is termination of resuscitation, has not yet gone into effect, because you're not even starting resuscitation on these patients. So what we're looking at now is a patient that you've decided to work, okay? And the literature now says that patients that are not resuscitated in the home have a very, very, very tiny, small chance of being resuscitated in the hospital. And the risk of transporting that patient, lights and sirens in the ambulance, does not outweigh the benefit to the patient. So in other words, you put that patient who's been down for 20 plus minutes in the ambulance and get into a wreck driving lights and sirens to the hospital, and you injure someone. There was really no purpose, because the chances of that patient actually being neurologically resuscitated and neurologically intact is so minimal. So the feeling now is that we should resuscitate the patients in the home, and that if we're not successful in the home, we should just leave the patient in the home for the medical examiner and the funeral parlor, and we should not be transporting those patients to the hospital. So now, what's our guideline to determine when we would want to terminate resuscitation? So they picked a 20-minute time frame. So they said after 20 minutes of resuscitative efforts, consider a decision based on one of the following. You're either going to terminate resuscitation, you're going to continue the efforts for, say, maybe 30 minutes instead of 20 minutes, and then you're going to, or you may transport, okay? So, and you see how it says transport in extenuating circumstances, because they're really kind of saying that if you don't save the patient, you should not really transport. Now, an extenuating circumstance could be what's going on with the protests and the riots and stuff like that. You have a protester that drops dead in front of 500 people, and you walk up and say, this guy's been down for, it took us 20 minutes to fight through the crowd. It took us another 20 minutes to get to the patient's side. This patient's been down for an hour. There's no purpose in resuscitating him, and you leave him. You'll now turn that protest into a riot. So there'll be certain situations where we may have to actually transport that patient away from the scene just to, keep the peace. Now, I'm not saying in that situation you're going to be driving lights and sirens to the hospital. You may just be, making it look good till you're out of sight, and then just shutting down and driving normally to the hospital. Okay, so let's go to the first one. That you're going to determine that you're going to terminate resuscitation. You're going to stop. You've tried for 20 minutes, 30 minutes, nothing's happened. Okay, you're going to stop. So they have a couple things here. So they said, have you considered end-tidal CO2? So BLS does not have end-tidal CO2. End-tidal CO2 is the measurement of exhaled carbon dioxide. And when we work a code and we intubate a patient, there's a device we clip between the endotracheal tube and the bag valve mask that monitors the amount of exhaled CO2. So to make carbon dioxide, our body has to have blood flow to the pulmonary capillaries that are wrapped around the alveoli, the air sacs, and it has to have air going to the alveoli. So that right now, with us being alive, our normal amount of CO2 we exhale is 35 to 45 millimeters of mercury. In a cardiac arrest situation, even with perfect CPR, since there's not a lot of blood flow to the pulmonary capillaries, even with perfect CPR, because we know perfect CPR is only about 20-25% effective as a beating heart, you're not expecting to see that 35 to 45 because you just don't have enough blood flow, right? You have to have blood flow and you have to have airflow to make it. So usually in a code, the airflow is accomplished by intubating the patient and using the bag valve mask. So you could get pretty much normal airflow in a cardiac arrest. You just can't get blood flow because CPR is not that effective. And even the Lucas is not 100% effective, you know, the Lucas mechanical CPR. So in a code, we're happy with anything above 10. So the reason they hear now is, you know, they're talking about end-tidal CO2 is the rule we kind of go by is that if we work the code for 20 minutes and the end-tidal CO2 never went above 10 millimeters of mercury, the chances of resuscitating that patient are nil. So they're going to call the code. They're going to basically decide they're not going to continue to resuscitate that patient and they're just going to stop. Okay. Now, on your level, we're going to go drop down here, right? And it says, because you don't have end-tidal CO2, it's going to say, does the patient care team agree to terminate resuscitative efforts? And if the answer is no, then you should continue efforts. Now, really what's going to happen in Rockland County is that, you know, more than likely either you're going to be there first, okay, and you're just going to decide, you know, that that patient wasn't workable because they've been down for an extended period of time and you're going to cancel the medics, or, you know, you decide that patient's workable and then paramedics are going to show up. Now, hopefully, I would assume the paramedics get to Piermont in better than 20 minutes on a code. You shouldn't really be sitting at the scene. So if you have a code that's workable, you should start CPR and move that patient to the ambulance. If the paramedics are not yet in the village, when you're in the ambulance and ready to go, you should start transporting. And you could always try to get intercepted by Medic 5 or something like that. Okay, so you're not probably ever going to terminate because of the 20-minute time because your on scene time is so quick and you're, you know, you guys are fairly, you know, Johnny on the spot. Okay, but let's say this is someplace where it's a little further. So if everybody agrees to terminate resuscitation, you have to say to yourself, does the patient meet the requirements for termination? So it says age 18 or older, arrest not witnessed by bystander or EMS, no bystander administered CPR, no automatic external defibrillator or manual shocks delivered, no return to spontaneous circulation. So that means the patient never came back in that 20 minutes, right? So sometimes we have a patient who comes back and recodes and comes back and recodes. If that's the case, then you technically can't, on your say-so, terminate the resuscitation. And at least 20 minutes. So if you answer yes to all of this, then you can call the code. Now we'll talk about that in a second. If the answer is no, it doesn't mean that you can't call the code, but it means that you would have to call medical control for approval, and that they're going to supposedly ask you, is the family okay with calling the code? In other words, is the family saying, okay, we've seen that you've done everything you can and the patient's been down for an extended period of time, and we don't want our loved one, you know, to be saved and then be brain dead and, you know, be on a ventilator in a nursing home for the rest of their lives. Okay, so let's go down now on this side. So the patient, okay, was good for all of this. Okay, so now ALS providers can terminate resuscitation without calling medical control, and BLS providers can terminate resuscitation, but they have to call medical control. Okay, so that's the only difference. So let's say, I don't know, you're out on a boat and you're no paramedics, you're out in a boat, you've been working, it's not a cold water drowning, it's the middle of summer, the water's warm. Patient's been down under the water for, you know, 10 minutes, they bring them to the surface, you start working them and it takes you, you know, 30 minutes or whatever to get to shore. I don't know, I'm kind of, you know, exaggerating. Because I can't really think of a situation in Piermont where you're going to have this extended, you know, 20-minute plus time. But let's just say, I don't know, you know, your boat dies or something like that. You know, if you were beyond that 20 minutes, okay, of resuscitative efforts, you could technically decide, you know, we've tried everything we can, this patient's not coming back, there's no purpose in continuing it. You would have to call medical control and explain to them the situation and get permission to terminate the code. The paramedics would not have to do that. Okay, so that's the only difference in that. Okay, once you decide not to continue resuscitation, you have to make sure the police are advised because they're going to have to call the medical examiner's office. Okay, now let's go back up here for a second. Okay, the patient was, I don't know, 16 years old. The arrest was witnessed. So now we go to no, that the patient didn't meet all these requirements. Okay. You call medical control. Okay. So they're going to tell you one of three things. They're going to tell you to terminate resuscitation, right? They're going to tell you to continue efforts for another 5, 10, 15, 20 minutes or whatever. Or they're going to tell you to start transport, continuing resuscitation. Okay, so sometimes they may say over here, just give it another 10 minutes, see if anything comes back. If not, then you can call it. Or they may say just transport. Okay, so that's what could happen if medical control can direct you to do that. Okay, now there's some key points. Okay, so when resuscitative efforts will not be initiated or terminated once initiated, okay, document this termination of resuscitation. Indicate the time that resuscitative efforts have been withheld. And it says, note the time that resuscitative efforts have been withheld and the time of death will may not be the same. We don't care about the time of death because we cannot pinpoint the time of death, right? That requires a medical examiner to conduct an autopsy to kind of get a rough. So we're just going to write down the time that we got there and the time that we stopped resuscitating them, okay? EMS cannot make a pronouncement of death, okay? So that's a fallacy. Sometimes cops will say to you, what time you're pronouncing them? So all you could say to them is, we are not allowed to pronounce death. That is a physician, but we can say that we're going to stop resuscitation at, whatever time it is. Okay. Now, those of you who've been doing this for 15 plus years, there was a medical examiner back in the day called Dr. Zugerby. You might have remembered him. He gave EMS a sheet of paper that had 10 things to look for. And it said pronouncement of death on the top of that sheet of paper. And I don't know if you remember, but you had to have a mirror and you used to put the mirror to the patient's face. And if it didn't fog up, that meant they weren't breathing. It was kind of like a whole bunch of silly stuff. So he had this like checklist that he wanted EMS to go through. And if EMS, answered everything as negative, the patient's not breathing, doesn't have a pulse, doesn't have breath on the mirror, so on and so on, you would then fill in a time of death on there. Okay. And that was something he just invented, and he was the medical examiner. And, whether it was 100% kosher or not, I don't know. But we used to fill in that form. There are some of those forms floating around. I taught the other night, and Pro River Ambulance had one of those forms. They were still using it, but it's not valid. EMS cannot pronounce dead, cannot assign a time of death. And the new medical examiner probably would laugh if they saw that. So that's just something, back in the day of, Rockland County, history. So if you still have those or you remember those, we don't do those. If you still have the little mirror, the little 4-inch by 4-inch mirror as part of your issued equipment, you can, use it for something else. Okay. Now, the last thing it says is once transportation has been initiated, okay, you can't stop it. So let's say you started to transport that patient, okay, and they recode or something like that. You can't at that point decide to stop the code. So once you make that decision to transport, you're committed, you're going to go all the way to the hospital with it. The only, I guess, possible difference in that would be if you're just transporting a patient to get them out of public view. Okay. So you're still going to have to transport them somewhere, right? Which is going to be the hospital because somebody has to take the body. But I would not go lights and sirens. If you're not working the patient, if you're not doing CPR and you're not working the patient, you can't drive lights and sirens because there is no emergency. And if you get into a wreck going lights and sirens and there's no emergency, you could be liable. You could be liable both civilly and criminally. So, if you're doing that kind of thing just to get the body out of public view and stuff like that, don't go lights and sirens. Okay. When you now taking a body to the hospital, right? So you're taking to the emergency room a patient that they are not going to be able to try to resuscitate nor be able to bill for. So they may not be so, what's the right word? So happy, they may give you a little bit of an attitude, but they do have to accept the body. Okay. And, if they give you a hard time with it and stuff like that, you can call me and, I'll get involved and stuff, but they do have to accept the body. They may not be happy about it, but they do have to accept the body. And then the other way, if they were the transporting facility, the sending facility, so they ask you to take this resident back to Piermont who's alive, who has a DNR, but is alive. So the DNR doesn't mean anything because they're alive. You put them in the ambulance, start going to Piermont, and they're on 9W and they see the traffic or the construction, they code and die. Okay. Then you don't resuscitate them because they have a DNR, what are you going to do? You can't bring them home, right? You can't bring this person to their home dead. So you have to turn around and go back to the hospital, and they have to accept it. The same thing if you were leaving a nursing home and the patient codes, you go back to the nursing home and they have to accept the patient. Okay, so any questions on any of this? So the two things you have to get into your mind is, when do you not start resuscitation because they're not a viable patient? Again, we said if there's an advance directive, a most form, or DNR, or if the patient has obvious signs that they've been down for an extended period of time where it's not worth trying to work them, or if the patient has mortal injuries, right? That they have injuries that are incompatible with life. Therefore, there's no purpose in trying to resuscitate them. In that case, you just leave them, and this protocol does not go into effect. This protocol is, it's a fresh code, you're working it, you've done the best you can, you get to the 20-minute mark, and the patient has not come back. The feeling now is that you would just terminate the code and leave the person in the house, okay? Now, again, if let's say this is an elderly couple, and you know, one of the two people dies, you're probably not going to leave, you know, that other elderly person, you know, in the house alone with their loved one, hopefully their loved one that they've, you know, lived with for 20, 30, 40 years, because it's just not the right thing to do. So in that case, you may decide to continue working the patient and transport them to the hospital, just because it's the, you know, it's the moral thing to do, the ethical thing to do in that situation. Okay, does anybody have any questions on this thing? Anybody have any circumstances they can remember where you had, you know, a similar situation to what we described or anything like that? Okay, so everybody's good with this? Okay, so let me shut this off. Now what I thought, whoops, what I thought we'd talk about a little bit is, what do we do when we deliver a baby and they're not healthy? So the first thing, let me just share the screen with you. Can you see the neonatal resuscitation? Yes? Okay. So the first thing is, thankfully, you know, 99.9% of babies, at least in our area, are born healthy, okay? And they do not need resuscitation. So what is that? What does that mean, born healthy? So what do we want to, what's our first determination when we deliver a baby that everything's going okay? So we want to know if it's what they call a term pregnancy. So term means that the baby has, you know, the mother has been pregnant for between 38 and 40 weeks. Okay, that's a normal length of gestation in a baby. So 38 to 40 weeks would be considered normal. Less than 38 weeks, it's a little premature. You know, less than 35 weeks, it's getting towards real premature. Over 40 weeks has some complications in itself, right? So when they're over 40 weeks, the problem is that they tend to be large, so it becomes difficult to vaginally deliver the baby, okay? And the other problem is that they can have a bowel movement while they're floating in the amniotic sac, because they've just been waiting so long, okay? And then they could aspirate that. That's called meconium. They can aspirate that bowel movement. So there's some risk of going past term. So when you arrive at a home of a woman who's in labor, you know, what's important questions to ask? So the book has all these things, you know, how many births have you had, how many live babies, how many dead babies, you know, So the first thing I always ask a woman is, are you a scheduled vaginal delivery? Okay, are you going to give birth naturally? Are you going to have a vaginal delivery? If she says no, I'm a scheduled C-section because of A, B, C, or D, at this point, you know your next step is to put the patient in the ambulance and start transport. Because if she's a scheduled C-section for whatever the reason, you're not going to do a C-section in the ambulance. So now you have to say, okay, I don't want her to give birth in my presence, you know, because I can't deal with it. You know, now, I mean, if it's an elective C-section because of, I don't know, some crazy reason, then maybe you can vaginally deliver it. But if she can't vaginally deliver it because the baby's too big, she's too small, there's complications, the baby's turned, you don't want to get involved in that, right? You just can't vaginally deliver that. So at that point, the treatment is drive fast to the hospital, because she's going to need a C-section, or she's going to need an obstetrician who can better manage her than we can, okay? So short of those situations, okay, most babies are born naturally, right? I mean, you got to remember, for thousands of years, babies were born without doctors, you know, without, you know, EMTs and paramedics, everything went fine. In fact, the most common situation was that the the woman who was giving birth, her mother and probably mother-in-law, or some of the other people in her family were present and helped her. It was probably only in the last couple hundred years where there were women who became like midwives type of thing and kind of specialized in helping deliveries and stuff like that. And actually having physicians participate in deliveries is really probably in the early 1900s. Before that, there was not really such a thing as OBGYN. Okay, so we'll talk a little bit about the concept of neonatal resuscitation. We'll talk about the guidelines and some different recommendations. This lady, Virginia Apgar, okay, she was the first doctor, okay, who basically had the concept that a baby who was born that was not breathing or not doing well could actually be saved. And as barbaric as it sounds, back in the day, we're talking early 1900s, a baby that was born not breathing, nothing was done for them. They were just left to die, okay? Because the feeling was there was nothing to do, okay? So she was the first doctor who kind of said, we could try to resuscitate these babies and, it could possibly work. And she developed what we use till this day somewhat, which is called the Apgar score, named after her. And it goes, appearance, pulse, grimace, okay, activity, and respirations. So it's kind of similar to the assessment we even do nowadays, okay? The problem with her scale is that the first assessment was done at 1 minute. And the feeling nowadays is you don't want to wait 1 minute to assess a baby, right? You don't want to wait. You want to immediately, at the time the baby is born, start assessment. So that was one issue, okay? And, kind of her thinking about it nowadays has been changed a little bit, but she really deserves all the credit for the concept of resuscitating babies, because prior to that, like I said, a baby that was born not breathing, there was nothing they really did. They may have slapped it once or twice, see if they can get it to cry, but there was really not much else they really did. So here's her scoring, and still on the New York State PCR, there's a place to fill in an Apgar score, okay? So it went from 0 points, okay, to 10 points of range. And there's the scaling of what you would give. And again, I think it was 1 minute and 10 minutes was her criteria. Okay, so nowadays the vast majority of newborn babies do not require resuscitation. Okay, they do require you to dry them and keep them warm, but they don't require actual resuscitation. And remember, moving from life inside the mother's belly to life outside is truly, when they talk about the miracle of birth, is truly a miracle, because when they're in utero and they're connected with the umbilical cord to the placenta, they do not need to breathe, right? So when they're floating around in that amniotic fluid, the blood is actually not circulating to the lungs. So what happens is we are made that when we're in the mother's belly, we have a hole between our right atrium and left atrium. So that normal blood flow, blood comes into the right atrium, goes to the right ventricle, goes to the lungs, gets oxygen, goes back to the left side of the heart, goes left atrium, left ventricle, and to the body, okay? Since they're not breathing, they do not need to have blood flow going to the lungs. So what happened is, whoever designed us made that when we're in utero, we have a hole between the septal wall, the wall that divides the left and right side of the heart. When it comes, Brandy's getting on finally. So what happens now when you were a little baby in your mother's belly is the blood came into the right atrium, and instead of going to the right ventricle, went through that hole to the left atrium, and then went left ventricle and pumped around the body. Because again, you were getting your oxygen from the umbilical cord, from the mother's oxygen through the placenta. So when you're born now, that hole obviously has to close so that blood starts going the right way. So what happens is, the concept of a vaginal delivery, like why do we have this birth this way? So when the baby starts to go down in the birth canal, that actual vaginal delivery has a role. That's squeezing and pushing the baby out, right, through the muscular contractions of the uterus, help to free up the amniotic fluid that's in the baby's lungs and airway, because they were floating in it for so long. And as soon as the baby is born and they take those first 2 or 3 breaths, those first two or three breaths that you took in your life were the highest pressure, okay, your lungs ever experienced, okay, hopefully, unless you had some kind of, crazy, I don't know, you were breathing compressed air or something like that that went out of control. So those couple of breaths you've took, okay, what they did was they actually expanded your collapsed lungs, and they changed the pressure inside your chest, inside your thorax, and the blood starts flowing in the right direction. Okay. So now that hole is still there. It closes up over about a week or two. Okay. But the blood actually starts to go right atrium, right ventricle, pulmonary artery to the lungs, then pulmonary vein back to the left side, and everything works. So you have heard stories of babies that were born with a hole in their heart. Everybody made a big deal about it. Every single one of us was born with a hole in our heart, or you wouldn't be alive. Okay. And that what happened is normally, okay, over a period of a couple of days to a week, that hole starts to close up. Now, some people, that hole doesn't close. And now the problem is that when their atriums contract, some blood goes the right way, but some blood goes back across to the other side and doesn't get to the lungs. And those babies are then born chronically cyanotic because they're not getting enough blood going to their lungs. And they have different things they could do nowadays. Years ago, it was surgery. Okay, but now they have ways of closing that hole through catheters that they actually bring up to the heart, in the baby. And some of this they can even do in utero. So, okay. But again, vast majority of babies don't require any intervention. Okay. Only about 10% require something to be done, which is again, not a whole lot, but only 1% require a full-blown resuscitation, talking, CPR and stuff like that. So the odds of ever having to do a newborn resuscitation are pretty minimal. Now, if you work in a place that has a lot of babies being born to mothers who may not have good prenatal care, to mothers who maybe not take care of themselves, maybe have obesity, may have drug use, or even mothers that have lots of babies, right? I mean, you got to figure the odds of having a problem, increase with every baby you have. And, the older you get. So if you're working in a place where women have 10, 12 babies, and continue having babies in their late 30s and 40s, the chances of running into a problem, increase. Okay. Or working in a place where there's, a lot of drug abuse, or working in a place where there's poor prenatal care. Okay. 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 So this is what we'd like to see at birth. Okay. So what do we have here? We have a baby, okay, who's got good muscle tone. Now they're wet, okay, and the color's not great. They're a little dusky, a little cyanotic. You see they're they're a little grayish in under extremities and stuff. It is normal at birth for a baby to be a little gray on the extremities. Okay, it's even normal for them possibly to be a little gray over their core, but that should on their core it should quickly go away. Okay, it's on their extremities where we are tolerant of it for a little longer and stuff. But the fact that they have good muscle tone, okay, and almost look like they're trying to cry and stuff like that, that's a good sign. Now, what we need to do, because this baby appears to be wet, is we need to dry this baby off. Now, I don't know if how many of you have seen a truly new newborn, right? A fresh newborn. Babies are born with a protective covering on their skin called Vernax. And it's kind of like a cheesecloth type of stringy material that's on their skin. So if you've never seen it, and this baby has it on him or her, I'm sorry, if you've never seen it, you may be concerned that this baby has been born with some type of defect, right? But that Vernax is a normal thing. And, when you get the baby 30 minutes after delivery, you're the proud parents or grandparents or something like that, they've already had a little bath and they've rubbed it off and stuff like that. So, but if we're doing a field delivery, sometimes they come out and they don't look like their skin is healthy, but that's just 90%, 99% of the time, just a Vernax. The baby's umbilical cord, you can see here, it doesn't look like the drawings of umbilical cords, right? It's kind of floppy and stuff like that. So umbilical cords are kind of a little floppy. The cord part of it is actually hard. So when you go to cut the cord, so to speak, after delivery, the scalpel actually works its way through. It's not an easy thing. And, common sense wise, always remember that you have to clamp, right, in two places, leave about 6 to 10 inches of cord attached to the baby. So you put your first clamp at about 6 to 8 inches, and next one an inch or two further along. And once both clamps have shut off the blood flow, then you cut in between. But it's not going to be like a scalpel cutting through a very easy thing. You actually have to do a little bit of a sawing procedure to be able to cut it. And just remember that when you do cut through it, there's probably going to be a little bit of blood that spatters out. Okay, and clamping and cutting cord is not a priority. We usually wait till there's no more pulsations in the cord. And that will tell us that all the blood is transfused from the placenta into the baby. So the minute the baby's born, the bigger priority would be to make sure they're healthy, right? That they're hopefully crying, and then dry them, because what kills babies is hypoxia and cold. So we have to very quickly dry that baby and wrap that baby, because we don't have the benefit of a radiant warmer to put the to put the baby underneath. Okay, so this is what they call the inverted pyramid of neonatal resuscitation. So in other words, these are the things we would have to do if the baby wasn't born term and wasn't born, vigorous and crying and stuff like that. Now, the reason they call it inverted is that the things on the top are more commonly done and the things at the bottom are less commonly done. Okay, so you could see, to the right there, it says 1.36 million babies born in the United States all have assessment done. Okay, only about 10 million babies have to go through a little more than that. Okay, and then only 6 million babies have to be ventilated, and only 1.4 million babies have to have chest compressions, and so on and so on. So you can see it's not very likely to get down to having to do CPR and ventilate patients and stuff like that. Okay, so here's our assessment criteria. If the newborn baby, okay, is born term, which again is 38 to 40 weeks, has clear amniotic fluid, and is breathing or crying and has good muscle tone, all you need to do, this is your 99.9% delivery. All you need to do is dry them, warm them, okay, possibly clear their airway, but we'll talk about that in a second, okay, and then go on with your assessment of their pulse and their skin color and stuff like that. Okay, so this is the vast majority of what we do, day in and day out. Okay, now you have to also kind of get an idea of, the size of the baby, right? So both of these babies are, healthy. Okay, they're crying, they have good muscle tone, but one is probably a good 4 pounds, 4 pounds heavier than the other. So what does that mean? If they're both healthy, it doesn't really mean anything in the world to us. Okay, but you just have to get the idea of size and stuff like that. When you're resuscitating. Now, why that baby, on the left side there as we're facing it, why that bigger baby is bigger could be a lot of different reasons, right? It could just be that it's going to be a bigger baby. Okay, it could be that it's gone beyond 40 weeks, so it's kind of past term and it's just continuing to grow. Okay, it could be that it was born to a diabetic mother, and since the mother was diabetic, she had higher sugars, the baby tended to get bigger, right? So that baby on the left, depending on the size of the mother's birth canal, may be a difficult delivery for a vaginal delivery, where the baby on the right side, as we're facing it, the smaller baby, would be obviously a much easier delivery. Sometimes you get babies like the big one. What happens is the head may come out, but the shoulders get stuck. It's called the shoulder dystoxia. Okay, so that may now kind of, you're almost there and you can't get the shoulders to deliver, and that becomes a true emergency. Okay, so what assessment parameters were missing from previous recommendations? So they used to say the baby had to be pink, but now they recognize that a baby at birth, immediately at birth, may be a little cyanotic, okay? So we kind of wait for about a minute. And again, it's normal for them to be cyanotic over their extremities for a little longer, but we'd want to see them pink up, okay, right away, over their core within a minute or so. Now, the other thing that's missing is the use of bulb suctioning. When you went to EMT class, you learned that when the baby's head came out of the mother and was on what they call the perineum, right, when the head was the presenting part, that was a good time to suction the baby's mouth and nose. And the rationale was that with the chest up in the birth canal, there was no way for the baby to breathe, so they couldn't aspirate anything and you could suction them. The feeling is, again, by study, there's no basis on that. There's no need for that. And it's just better to deliver the baby. So we don't do routine bulb syringe suctioning on the perineum. Now, if the baby's head shows and you see meconium all over the baby's face, you may want to, wipe the baby's face, and you may want to use the bulb syringe to see if you can suction out any meconium that's in the mouth and nose before the baby's born, so that they don't aspirate any more meconium. Okay. So the real reason they kind of did it was they felt it just kind of slowed things down, and there was other priorities to do. Okay, so now other babies that may need resuscitation. So what do we do? So our initial steps are, we're going to dry the baby, we're going to wrap the baby, we're going to start our assessment. Okay, we have to position the baby. So we have to put them flat on their back. Okay, we don't do head tilt chin lift on babies. We kind of keep their head in a neutral position. To help keep the head in a neutral position, sometimes we put a towel roll under their shoulders, because the back of their head, their occiput, right, is very rounded and pronounced. So sometimes when they're laying flat, because their head is so pronounced, they actually flex forward and close their airway. So if that's the case, the way you deal with it is put a towel roll under their shoulders to raise their shoulders to the same height as the back of their head, so it keeps them in a neutral position. Okay, we'll talk about the possible need for ventilation. We'll talk about the possible need for chest compressions. Obviously, B and C are not so common. D, you're not going to be doing in the field anyway, right? So now we look at three things. So again, now we're saying that it wasn't that term baby that was all wonderful and crying and everything was good and stuff like that. So we have a baby that we have to go on and say, okay, they missed one of those criteria, so we have to take a better look at them. So we're going to look at three vital signs: respiration, heart rate, and skin color. So anybody have any idea of what a baby's normal respiratory rate and heart rate are at birth? Anybody have any idea? So a baby's normal respiratory rate at birth is 40 to 60 breaths per minute. Some people say 30 to 60, but that's fast. And if you didn't know that, like we didn't talk about that, and you saw a baby breathing 60 times a minute at birth, you would be concerned, right? Because we don't do this day in and day out. You say, who the hell, who have you ever seen breathing 60 times a minute? Now, the other thing that's interesting is what's the baby's normal heart rate, okay, at birth? So the baby's normal heart rate at birth is approaching 150 beats per minute, right? And you're going to see when we go on that we define a heart rate of 100 as the bare minimum for a baby to be alive. Okay, so now, from an adult standpoint, we would say a heart rate of 100 is tachycardia. But in a newborn, we're looking more of a heart rate of 150, 160. And we said as far as skin color goes, we'd like to see the core over the chest and the abdomen pink. We'll tolerate some extremity cyanosis for a couple of minutes. Okay. Now, we basically only wait about 15 to 30 seconds between each check, right? So every time we check a baby, we're checking until they're 100% stable. We're checking them every 15 to 30 seconds. So we're not delaying, resuscitation. Now, there's only two ways to check heart rate. So the whole concept that you learned in CPR of the brachial artery is a joke. Try to find your own brachial artery. Right now, it's pretty hard. And the brachial artery in a newborn is a very, very hard artery to assess. The blood pressure in a baby is low. You're going to be scared, so you're going to press hard, right, to try to find it, and you're going to shut it off, and you're not going to be able to find it. So there's only two ways to assess heart rate in a newborn. The best way would be to feel the umbilical stump. So if you kind of look down by the umbilical cord, that umbilical cord has been cut, that those hemostats are on there, those clamps are on there. Okay, and they're feeling between the clamp and the baby, right? So that section of cord they have their finger on, even though it kind of looks a little distorted, is actually still attached to the baby. And they're feeling the baby's pulse in that umbilical cord, because your umbilical cord ties right into your portal vein. So it actually, you feel a pulse, because in an umbilical cord, there's an artery and a vein, and you actually feel a pulse. That's the best way. Now, again, remember that blood pressure in that umbilical cord is minimal, right? 40, 50. So if you squeeze too hard because you're nervous, you're just going to shut it off, and you're not going to say there's no pulse. So it's just a little gentle pressure. And because it's so fast, right, 120, 150, sometimes it's hard to differentiate the vibrations of the pulse. So it is hard. The other way you could do it is you could take your stethoscope and listen for what they call the apical pulse over the heart, okay? So those are the two ways you can assess heart rate. Obviously, the umbilical is better because you actually feel the pulse, so you get an idea of the strength of the pulse, where the other one, you're just listening for the actual opening, closing of the valves of the heart. Okay, so now this is the resuscitation. Let me go over to here. This is a little better view. So when we're talking about resuscitation, we'll start from the bottom. The first thing we said is it a term gestation? Is the baby breathing or crying, and do they have good muscle tone? If the answer is yes, the baby can stay with the mother and basically gets routine care, which is drying and wrapping to prevent heat loss, okay? If the answer was no, okay, we're still going to dry them, we're still going to prevent heat loss, we're still going to open their airway, and now we're going to do some what they call tactile stimulation to try to wake them up a little bit and increase their heart rate. So what's tactile stimulation? It's rubbing the small of their back or flicking your fingers on the soles of their feet to try to wake them up. After you do that, you're going to do an immediate check for a heart rate. Now, we said a normal heart rate is 150 to 160. So here they're going to give you 100 as a cutoff. And they're going to say if the heart rate is below 100 or the baby's gasping or not breathing, okay, you have to do something for them. Now, remember, 100 is not a good number. You want the heart rate to be to 150, 160. So if you had a baby who was born with a heart rate of, say, 110, you can't say, hey, that's not so bad, right? Because it really should be 150 or 160. What you'd actually do is give them some blow-by oxygen, okay, to kind of raise their oxygen level and see if that increases their heart rate. But if it's below 100, then we have to start doing something. And what we do is we initiate what's called positive pressure ventilation. That's their way of saying you're using the bag valve mask. It's not the old demand valve or anything like that. So you're using the positive pressure ventilation. If you have a way of doing pulse ox on a newborn, which you probably don't have, that requires having the kind of stick-on probes that you could put on the, you know, the toe or the earlobe or something like that. You can kind of gear it towards the oxygen saturation. If you look down the lower right, they're saying that a normal O2 sat at birth at 1 minute is 60 to 70. And you see how it, as the minutes go by, it starts moving towards what we'd expect to be, you know, a more normal range. Okay. So going backwards again, this baby was not born 100% healthy. Okay. So they were born, you wrap them up, you dry them, keeping them warm, and you assess their heart rate. If their heart rate's above 100, okay, but below 150, give them some blow-by oxygen. If it's now below 100, you have to start ventilating them with the bag valve mask, okay? So what about the bag valve mask? So the first thing is, normally whenever we use a bag valve mask, we always hook it up to supplemental oxygen. In this case, with a newborn, you do not initially ventilate them with a bag valve mask with supplemental oxygen. You initiate the bag valve mask with just room air, okay? And the reason why is that none of us are really born to be ventilated with 100% oxygen, but babies are very sensitive to 100% oxygen, and they may actually go the other way and start vasoconstricting down and decreasing organ perfusion. So at least initially, okay, we kind of ventilate them with room air for the first minute or two. Okay, so we're going to initiate positive pressure ventilation, okay? If the heart rate continues to be below 100, we're going to make sure that we're getting adequate air in. We're going to make sure that the airway's open, there's no leaks under the mask or anything like that. And we consider maybe ventilating them with a little more pressure, and now maybe adding some supplemental oxygen to it, okay? If the heart rate at any one point drops below 60, we actually have to start CPR on them, okay? So now we were saying the heart rate's below 100, but it was above 60. As long as it's below 100 and above 60, it's not great, but we just do ventilations on them. If at any point the heart rate drops below 60, we add CPR in, okay? Now, neonatal CPR is a little different than infant CPR in that the rate of compressions is 120 compressions per minute, where normal CPR is 100 to 120 compressions per minute. And the ratio of compressions is 3 to 1, where typically in two-person infant CPR, it's 15 to 2. So this is just what the American Academy of Pediatrics recommends when you're doing a newborn resuscitation. If you didn't yet add oxygen to the bag valve mask, you would switch to 100% oxygen. And if you're having a hard time getting chest rise with just the bag valve mask alone, you would consider intubation or use of a laryngeal mask airway, okay? And if the baby's heart rate continues to stay below 60, that's when you get into, you know, the paramedics would get into more advanced things. Personally, in Rockland County, I would just drive fast to the hospital. I don't think I would start getting into trying to get, you know, venous access and giving meds or anything like that in a baby that's that bad. Now, I've been doing this, you know, probably close to 35 years. I've had one newborn resuscitation. It was at Rockland Psych. It was a baby that was born to a drug-addicted mother. And she told the people at Rockland Psych that she was having contractions. They sent her to Westchester. Westchester sent her home saying it was preterm labor. She came back in, said she was still having contractions. So they called 911 again to have her sent to NIAC this time. And we walked in the door. She said, I'm having my baby. And everybody's telling her, no, you're not having your baby. The hospital said you're not. And she turned on her side. She lifted her leg and the baby's head came out. And then she squeezed one more time and the whole baby came out, and it was just basically lying there doing nothing. This tiny little baby. And, you know, we had to do a newborn resuscitation on it. Okay, so that's the only time I've ever had it in Rockland County in 35 years. So it's not a common thing. Now, if you worked in a place that had a higher birth rate, especially to older mothers or mothers that didn't have good prenatal care, you probably have been doing a few of these. Okay. Now, how do we maintain body temperature? Okay, so you may have on the ambulance those silver aluminum foil sleeping bags. So the American Academy of Pediatrics hates those, okay? Now, cold is definitely a killer to babies, just like hypoxia is a killer to babies, okay? In the hospital, they put them on what's called a radiant warmer. You kind of see sometimes in a restaurant, the food is kept under these warmers and stuff like that, where there's kind of, you know, a certain type of light bulb in there But we don't have those, obviously, in the ambulance. So what we do is we remove any wet linen, we dry the baby, okay, and we wrap them in dry towels. Okay, the paper towels and stuff they give you in the OB kit are useless. They're good, okay, for drying, but you're not going to be able to wrap the baby. So you're just going to use regular towels and stuff like that to wrap the baby. If you have anything you could fashion into a little cap over the baby's head, that would be beneficial. Now, what they prefer, okay, in the hospital is these clear plastic bags that are actually designed that a baby goes in. They actually have a headpiece to them. It's not over the baby's face, it's just over their head. And they actually prefer that. And they say that you actually see condensation inside the bag if the baby is warmer than the room. The reason they don't like the silver swaddler, okay, is that you cannot see the baby's chest moving. So you're going to have to open it to make sure the baby's breathing adequately. And if you have to unwrap them, you're defeating the purpose of temperature maintenance. So that's why they prefer the clear plastic bag, because obviously through the clear plastic bag, you can see. Now this is food grade, plastic. It's not going to leach any chemicals into the baby or anything like that. And they make them nowadays specifically for this. And it kind of looks like a little mini sleeping bag that has like an integral head part to it, and is elastic typically in the head part, so it doesn't slide over the baby's face or anything like that. So we do not have them. I think the baby bus that comes and picks up the babies and staff flight and stuff, they have them. But you could fashion something out of towels and stuff like that. If you had to use supplemental oxygen, okay, so we're talking about a situation where the baby's born with a heart rate, a little above 100, but not yet 150. Maybe they're a little cyanotic over their extremities, but their core is pink. So they're not really that bad, but they're not exactly where they should be. So you don't need to ventilate them because their heart rate's over 100, okay, but you need to do something for them. So again, you would use what they call blow-by oxygen. So you could do it two ways. You can do it with a pediatric oxygen mask, or you could just do it with the end of the oxygen tubing. And they say that if you hold the oxygen tubing about a ½ inch away from the baby's face, okay, and run it about 6 liters, that would be an adequate amount of oxygen. And then what you do is you continue to monitor the baby's heart rate. And if the baby's heart rate starts climbing like it wants to, right, you want it to go towards 150, what you would do is once you hit 150, you'd start slowly increasing the distance away from the baby's face so that you're kind of weaning them off the oxygen. You don't just all of a sudden shut the oxygen off because they may go backwards. So you just start increasing the distance away from them with the oxygen. Now, some of you may say, I've heard, oxygen around a newborn can be dangerous to the eyes and dangerous to this and dangerous to that. So we're talking, short-term minutes worth of oxygen use. We're not blowing it on their eyes. We're blowing it in front of their nose and mouth. Okay. And, if you really were super concerned, you can cup your hands, around the baby's nose and mouth and just have it blow in that situation. But, just blow by oxygen is fine. Again, the indication would be that the baby's born with a heart rate above 100. So you don't have to start positive pressure ventilation, but they're below 150 and maybe they're a little, centrally cyanotic. They're not pinking up as quick as you would like. So you can give them some supplemental oxygen. As soon as their heart rate starts to approach 150 and their skin starts to pink up and you're sure they're dry and warm, then you start increasing the distance and weaning them off the oxygen. And once you're probably, a foot away from their face, you could just, and their heart rate is still staying at the number you're happy with, you can just DC the oxygen at that point. Okay, so that's just showing you some different ways to be able to do it. Okay, so it says here, once adequate ventilation is established, okay, if the heart remains low, the priority should be support cardiac output with chest compression. So what they're saying is, once you know the breathing is okay, but yet their heart rate starts to slow down, the only way to then help them is to do CPR. So I know for a lot of us, it's weird to say that you would do CPR on a patient who has a heart rate of 60 or 58, but that's that is too low of a number to support life, right? At birth, that baby's heart rate should not be 60, 62 or something like that, should be more towards 150. So that 60-ish is very incompatible with life. So in that situation, again, we said we would do CPR. It's 3 compressions to 1 ventilation at a rate of 120 compressions per minute. Okay, again, if you have a baby with central cyanosis, we talked about the supplemental oxygen. Okay, 6 liters per minute, about a ½ inch away from the face. Now, meconium. So meconium is the baby's first bowel movement in utero. It could be caused by 2 things. It could be caused by a very broad term called fetal distress. So fetal distress means that the baby's oxygen level, and we don't know why, but the baby's oxygen level dropped temporarily. Because their oxygen level dropped, all their muscles in their body relaxed because they were hypoxic. So their anal sphincter muscle, which keeps your poops up inside of you, okay, it's the one that sometimes when you think you're having a, diarrhea and you're running to the bathroom, it's the one you clamp down on so you don't have an accident, right? That's your anal sphincter muscle. So that hypoxia caused that anal sphincter muscle to relax, and the baby had their first bowel movement in utero. The problem is that feces then floated in the amniotic fluid, and the baby sucked it in and out of their airway, and they could develop what's called an aspiration pneumonia. They can get an infection in their lungs from it. So that's one cause. Okay, one cause is that they had fetal distress. Maybe, I don't know, the mother was an asthmatic and she got hypoxic. And because she got hypoxic, the baby got hypoxic, because again, the baby's dependent on the mother for oxygen. And also the other situation is the baby goes past term. So now, they're 40, 41 weeks, 42 weeks, and the baby's been holding that bowel movement for, 40 weeks. It can't hold it anymore and it goes to the bathroom. But either way, meconium, is dangerous. It can cause an aspiration pneumonia. Okay. There's a term, meconium aspiration syndrome, where a baby's born with meconium staining in their bradycardic, and they're difficult to manage and stuff. So we use the following criteria. If a baby's born with a little bit of meconium that's kind of watery, not very thick and pasty, and they're active, they're crying and they're moving, we don't consider that to be a high priority. If the baby's born not breathing, not moving, breathing poorly, but not moving, a lot of activity, and they have thick, pasty meconium, kind of more looking like poops, that we consider to be a little more of a priority patient. The one that's born with thick particulate meconium, when the paramedics arrive, they're going to have to suction, but they have a special way of suctioning that baby that on a BLS level, we don't have, right? We don't have that opportunity to be able to do that. Either way, if you're delivering that baby to the hospital, you have to point out to the nurse that there was meconium, because that baby may need to be monitored and may need to be put on antibiotics. Okay, so this meconium aspiration syndrome, right? So intrapartum suctioning is when you're going to suction the mouth and the nose with the bulb syringe, okay, when the baby's head's on the perineum. That is not really recommended anymore, okay? But I wouldn't say it's terrible. If you have a second, you saw a baby that was born with meconium and you have a second to be able to do it because the mother's between contractions, it wouldn't really hurt, okay? But routinely, we don't do it. Now, deep tracheal suctioning, okay, is what's done when the baby's born with thick particulate meconium and they're not active, they're not moving. So you need this device that's kind of in the center over here. And what basically happens is this device hooks on the end of an endotracheal tube, okay? The suction tubing that you use to put on your suction catheter hooks on the other end. And you see how there's this little chimney over here? This has a big hole in the middle of it. So until you put your thumb, like they have over here, there's no suction. So what happens is we intubate the baby with the endotracheal tube. We then attach this device to it. We put our thumb over it, and now there's suction pulling through the endotracheal tube. And since when we intubated them, we obviously are putting the tube in the trachea. If there was any meconium that made it down into the trachea, you're going to now suction it out. Okay, so that's the procedure that they would do to get it out and stuff like that. So most studies point towards that intrapartum suctioning when the head just comes out. That's not really beneficial. Doesn't reduce the incidence of meconium aspiration syndrome and stuff like that. Okay, so it's not really recommended for us to do that anymore. Okay. This is again showing you how the meconium aspirator, and obviously we want to limit our suctioning because while we're suctioning the baby, one, we could stimulate them to get bradycardic by giving them like a vasovagal type of reaction. The second thing is that we're not ventilating them and we're pulling oxygen out of them, so they can just get bradycardic from that standpoint. So suctioning 2 seconds or less, and 2 seconds is a long time when you're applying suction. Okay. As far as ventilating them and stuff like that, we're not 100% certain how much pressure, we're not 100% certain how fast. It's all kind of the best guess type of thing. So the initial pressure we shoot at about 30 or 40 centimeters of water. Your newborn bag valve masks have a pressure relief valve on them. I'll have to point that out to you, but every neonatal, every pediatric bag valve mask has a pressure relief valve, even every child bag valve mask. It's a little switch that typically is in the open position, and if you ventilate with more than 40 centimeters of water pressure, it'll vent the extra pressure to the atmosphere to protect the baby. But it also has the ability to isolate it and shut it off, and that's because, let's say you want to ventilate this kid, and their lungs are a little tight because maybe they had a little aspiration and you can't get air in, it's venting out to the atmosphere, you can then shut off that pop-off valve and whatever you squeeze goes into the baby. But the onus of responsibility is on you, right? Because if you overventilate with too much pressure, you can cause a pneumothorax. Okay, so most of the times they're in the open position as a safety. Okay, and again, we said that since the baby's normal heart rate is somewhere between 30 and 60 breaths per minute at birth, that's actually the rate that we ventilate them at. Okay, if we had to use the bag valve mask. So you should have your equipment for resuscitation in a separate little, box, so you don't have to, in an emergency situation, flop around and try to find it. And remember, a neonatal bag valve mask is a little smaller than an infant. So most ambulances only have an infant, a child, and an adult. A neonatal is about 3/4 the size of an infant. So it just makes it less likely for you to overventilate the child and stuff like that. And your bulb syringe and all that stuff is in your OB kit, so you don't really have to have that separate or anything like that. Okay. Neonatal bag valve masks usually have a pressure gauge on them, so you could see how much pressure you're delivering to them, so you don't overventilate them. You should have numerous size masks because obviously that baby's face size is going to be different. There'd be different sizes for different size baby faces and stuff like that. Okay, we keep the head in a neutral position. Okay, and we ventilate at a rate of 40 to 60 breaths per minute. Again, you don't have to worry about the intubation, but there may be some certain situations where the paramedics may choose to intubate the baby. Most paramedics have never intubated a baby, so they're going to be nervous and stuff like that. But, the main indication would be there's meconium, okay, or you can't get chest rise when you're using the bag valve mask. That's the main two indications. Again, just showing you certain size endotracheal tubes. So, if a baby's born under 1,000 grams, we typically use a 2.5 and so on and so on. At birth, most babies get intubated, a normal healthy baby at birth, 3.5 endotracheal tube, okay? You always wanna mark, there's numbers along the endotracheal tube, so you wanna mark the number that lines up with the baby's teeth or lips so that later you can monitor whether or not the tube gets dislodged. In other words, if the numbers doesn't line up anymore, it either got pushed down into the baby or pulled out of the baby and stuff like that. Now, this is talking about, you're having a problem ventilating the baby, okay? You're not getting good chest rise. What should you think about? So the first thing is maybe adjust your mask seal. Maybe you don't have a good seal and you have leakage. The second one, we reposition the head. Okay, make sure the airway's open. There may need to be some suctioning, okay? And so on and so on, going up to the point of actually getting them intubated. But usually most of the times with repositioning the mask and repositioning the airway and maybe squeezing with a little more pressure, you will get chest rise. Remember, these kids at birth are born with like stiff lungs, right? Because they have not been using those lungs to breathe. So it can be a little difficult. We said the indication for compressions was a baby we were ventilating because the heart rate was below 100. And the heart rate, instead of climbing above 100, actually goes below 60, okay? So if it goes below 60, we start CPR at a rate of 3 to 1, okay, at 120 compressions per minute. And this is going to be where you have the hands encircling and you're using your thumbs on the baby's chest. That's the type of CPR we'd be doing there, like this, okay? So just giving some ideas of baby size and stuff like that, okay? So all the way to the left as we're facing it, okay, is a preterm and low birth weight baby. The middle is a full term, okay, but a little low birth weight. And then the middle one, I'm sorry, the one all the way to the right is a full term normal birth weight baby. So it's probably about a, 7 to 8 pound baby, would be about the normal birth weight. Okay, so that's basically everything I had to go over tonight. Does anybody have any questions on anything? If you do, unmute yourself. The only other thing I wanted to go over with you was the quiz that you're going to take. So I will email out the link to the quiz once we finish it, but let's just go through it, make sure there's no questions. So if you have a question, unmute yourself. So I wrote, you have assisted in the delivery of a 37-week-old infant that was born to an opioid-addicted mother. So this mother was addicted to fentanyl or heroin or whatever. The child appears small for gestational age. Possible complications that this child may face due to the possible maternal opioid use include what? So we're saying a baby that's born to a drug-addicted and opioid-addicted mother, what are they going to face? Okay. So low birth weight is one, definitely, right? A decreased respiratory rate would also be, because we know one of the things we look for when we look for an opioid overdose is a slow to absent birth rate, okay? Decreased tidal volume means how much does their chest expand to breathe? So that's another issue with opioids, right? It decreases their tidal volume. And then temperature control issues, okay? So all of those are possible complications that you could see in a baby that's born to an opioid addicted mother. Okay? You have assisted in the delivery of a 37-week-old infant that was born to an opioid-addicted mother. The child appears small for gestational age. Your first assessment reveals a heart rate of 96, a respiratory rate of 20, and central cyanosis. So if you remember what we just spoke about, we said the heart rate should be more towards 150, right? So now it's under 100. So the first thing is that's an alarm. The respiratory rate, we said it should be between 30 and 60. This respiratory rate is 20. That's a second alarm. And now they have central cyanosis, which really we only kind of tolerate at birth, peripheral cyanosis. So this kid has like 3 strikes against them. So we said, how should this child be managed? So routine care. Okay, so this kid's a little too far to the left for routine care, right? They're a little too sick. Positive pressure ventilation at a rate of 40 to 60, administration of 4 milligrams intranasal Narcan, okay, or oxygen by blow-by oxygen by face mask at 15 liters. So let's go through them. So number 2 is probably the right answer because their heart rate's below 100, right? Giving a baby, a drug-addicted baby, because the mother's addicted Narcan, will throw that baby into withdrawal. So we never do that, okay? We never administer naloxone to a baby that's born to a drug-addicted mother. That's something that has to be done in a hospital and titrated very, very carefully, because as dangerous as slow breathing is, okay, throwing a baby at birth into withdrawal because you gave them too much Narcan would be equally as dangerous. And the supplemental oxygen is not bad, okay, but they're only breathing 20 times a minute. So it's not really going to be so helpful because their respiratory rate should be faster. So the only way we can increase their respiratory rate is to use the bag valve mask and ventilate them at a faster rate. So on this one, I would put number 2. Don't bother writing down like, you know, question 3 is C or something like that, because the computer program scrambles all the questions. So they're not going to be in the same order when you actually take it. You have been providing positive pressure vent. You get 3 tries. So, and it tells you what you got wrong each time. So you really can't fail the test. You've been providing positive pressure ventilation to a 36-week-old newborn who has a heart rate of 80 at your initial assessment. So because the heart rate was below 100, we have been doing positive pressure ventilation on this kid. After 30 seconds of positive pressure ventilation, you note the heart rate decreases to 50. So we'd expect it to go to 150, but now it's actually gone the other way and it's gone below 60. So now we have a problem, right? So what do we need to do? So technically we need to start CPR on this kid. So let's go on. So our choice is to continue positive pressure ventilation, which obviously we would. And it says start chest compressions at a rate of 30 to 2. So if you remember back to how we do neonatal CPR, we do neonatal CPR 3 to 1, right? So the right choice would actually be B. Continue ventilating them, start chest compressions at a ratio of 3 to 1 at a heart rate of 120 compressions per minute. That's how we do neonatal CPR. Okay. The routine bulb syringe suctioning of a vigorous newborn, that means a healthy newborn, should be performed as soon as possible, as soon as the child's head has been delivered. So years ago that was true, but nowadays they say there's no reason to do it in a healthy newborn baby, okay? It just slows things down and raises the risk of vasovagal and stuff like that. So that would be a false, okay? Meconium is the baby's first bowel movement, which occurred in utero. The answer is yes, right? So again, you know, that shouldn't happen, okay? But sometimes because of fetal distress or because the baby's been inside the mother for too long, it happens. Okay, possible risks of meconium aspiration include meconium aspiration syndrome, yes. Hypoxia, yes. Hemorrhagic shock. So hemorrhagic shock means bleeding, you know, loss, shock from bleeding loss. So meconium aspiration has nothing to do with bleeding, right? So that wouldn't be a right answer. And the bradycardia would be true. And the reason the bradycardia would be true is because if the child is hypoxic, the heart needs the oxygen to beat. So if they're hypoxic, then they would have bradycardia. So this one, the right answer would be 1, 2, and 4. Acceptable methods to provide supplemental oxygen to a newborn with a heart rate of 110 who has persistent central cyanosis. So what are we talking about here? The baby's born, okay? and their heart rate is 110, which is not horrible, right? It's above 100. We'd like it more towards 150. But because they have persistent central cyanosis, now we're concerned a little more, right? Because we'd expect that their core would pink up after a minute. So what do we need to do? So we said we would give them some blow-by oxygen, right? That's how we would treat them. So A, C, and D are a little too aggressive, are not called for in this situation because the baby's heart rate's above 110. But B would be the right answer to start with. We give them some supplemental oxygen by blow-by at 6 liters per minute, held approximately 1 inch from the baby's face. And if their heart rate starts to increase and their central cyanosis starts to go away, then we can start increasing the distance, okay, over 5 minutes or so, back it off a ½ inch each time. And as long as their heart rate continues to climb and their central cyanosis continues to go away, we would then discontinue the supplemental oxygen. So figure the whole thing probably would take you about 10 minutes to kind of give them the oxygen, let the oxygen do what it needs to do, to get their heart rate up and get rid of the central cyanosis. And then we wean them off it, right? So we don't suddenly stop it. We slowly cut them off from it over face 5 minutes, 10 minutes or something like that. So we don't just kind of withdraw it from them suddenly. Okay, question 8. The two main causes of increased morbidity and mortality, so it's illness and death in newborn babies, are hypoxia and hypothermia. So yes, right, that's a true answer. The two reasons babies die are they're hypoxic or they were not dried and warmed and wrapped up and they die of cold. Question 9. The risk of hypothermia in newborns can be reduced by which of the following? Okay, drying the baby as soon as possible would be yes. Removing any wet linen and clothing from the baby as soon as possible, yes, right? You don't want any wet clothing to draw away the heat. Increasing the ambient temperature in the patient compartment of the ambulance would be yes. Okay, the warmer the area they're in, the better it would be. Providing supplemental oxygen. So we don't routinely give oxygen to every baby, right? So in this case, 1, 2, and 3 would help with keeping their temperature. We don't need to give them oxygen to keep their temperature up, and we don't routinely give oxygen to every baby. So this one would be 1, 2, and 3 are correct answers, choice A. And then the last one, what's the maximum interval we should allow for interruptions in chest compressions, right? So this is a routine CPR question. We never want to interrupt chest compressions for longer than 10 seconds, which sometimes is going to happen if you have to carry people down flights of stairs or something like that. It may happen, but routinely, we don't want to interrupt for greater than 10 seconds. Okay, so does anybody have any questions on anything we went over tonight, or any questions on anything they want to discuss, on anything, COVID or whatever? Remember, we please do not let your guard down, even though it's kind of mellowing out a little bit. We're probably going to have a second wave. I mean, I wouldn't say probably. We are going to have a second wave. Whether it's going to happen over the summer or once the schools open in September, we are going to have a second wave. We see that there's increased incidence of COVID now in states where they've reduced their social distancing and all that stuff. The only positive note is that the virulence of the virus, the ability to cause serious illness of the virus, in most cases, at least in New York, seems to be dropping, right? We still have COVID patients, not at the same rate, and they're not quite as sick as they were, okay? If you go back a month, 6 weeks ago and stuff like that. Some people say the virus has mutated a little bit and changed and got a little weaker. Some people are saying that most of the weak patients have died off, and now it's infecting otherwise healthy people, so they're not getting quite as sick. But the long and short is, it's not like, I mean, again, I don't know how bad it hit Piermont, but, if you go out throughout the county, I mean, we were having people who supposedly were sick for a day and then dying. We were walking into assisted livings and having 5 or 6 dead people in rooms, each one in their own bedroom. Nobody even knew they were dead. So, I mean, it was bad for a couple of weeks, but we don't really, see that anymore. We do have that little incidence of the multi-system inflammatory syndrome in the babies, and not the babies, but in the younger patients. That seems to also have, kind of mellowed out a little bit. They just published some data in New York State where they said the average age of the patient who got it was 5 years of age. The range was from 4 to, I think it was 14 or 16. Again, just statistically, so the average age, again, and that most of the kids who got sick were obese. So they were little kids who were obese. About 50 to 60% of the kids who got real sick were obese. So, just some background information, but that also seems to be kind of on the downside. And again, it's because that syndrome tended to hit at the 30-day post exposure, okay? And we're beyond 30 days for most of us who've been, around it and stuff like that. So unless we have a second wave, you're going to see less and less of that multi-system inflammatory syndrome in children until we have a second wave, and then it'll be 30 to 45 days after that second wave. So you should still be wearing your PPE. You should still be putting masks on patients if you have any suspicion of, COVID. Yes.
Frank, how long do we have to get this test done?
As long as you want. In other words, you don't get your
do the last one.
Okay, it doesn't matter. So you don't get your CME certificate until you get at least a 70 on the test. So you could do it now, or you could do it 2 years from now. It doesn't matter. Just follow the link. It'll be there. And if you have any problems, just let me know and I'll, resend it to you or anything like that. So it does not matter when you do it. Like I said, you have 3 tries, and I have not had anybody. I mean, I've had people who've gotten, a 20 on the first attempt, and then a 60 on the second attempt, and then 100 on the third attempt. So, it's just to make you, we're getting 3.5 hours of credit. We're not talking for 3.5 hours. So just to make it a little more legit and, make you, do a little thinking and stuff like that. Okay.
All right, good.
Any other questions on anything else?
No, just one other comment though. You were saying that a normal pregnancy is 38 to 40 weeks, but haven't they changed that? I thought in Massachusetts the neonatal people were saying actually what's considered you're not past term until you hit 42 weeks now.
I've never heard that, but I could do some
41
research.
weeks and 6 days or something, I think is what they're saying.
Yeah, I've never heard that, but I could research it, but no, I've never.
I actually was just reading it, and it came. It was actually in a New Zealand article, but it came out of Massachusetts.
Okay, I pity the moms that are now carrying kids for 42
that was
weeks.
Me, so
yeah,
41 and a half. So
yeah, 42 weeks. Is a long time to be pregnant, and they also tend to be bigger, obviously, at that point. So the delivery is a little more difficult and stuff. So hopefully it's not the norm. So. Okay, so anything else? Okay, so please, keep your guard up. Okay, and don't get lackadaisical. I know we're all enjoying the nice weather and getting out and stuff like that, but at least on EMS calls, don't be lackadaisical and anything like that, because it's not done yet. It's not going to be done until either we have total herd immunity, where we have the vast majority of the population already exposed to it and they have antibodies, or we get a vaccine. And they're really questioning the validity of the antibody tests and stuff like that. So if you did get a test and they told you had antibodies, it doesn't really mean anything, because they don't know how valid these tests are or anything like that. So, okay.
All right, thanks, Frank.
Any questions?
Thanks, Frank, for scheduling for next month, right?
Yep. I'll try to get it out earlier. It just completely slipped my mind. Okay,
Okay,
everybody.
and anybody on here, don't forget Friday night, we have the call for the EPCRs from 7 to 10.
Okay. Enjoy your Friday night. Enjoy your weekend. Stay safe. Okay. And
you too, Frank.
We'll see each other in a month. Take care.
Bye.
Night, everybody.
Night.
Night.